Okay, so until now we saw and discussed about epithelial tumors, the first group from the classification of tumor, which is by far the most frequent one. And we saw already that for the squamous and urothelial stratified epithelia, the benign tumor is called papilloma. Being a pseudotumor, in fact, resulting from human papilloma virus infection mostly for the screen and the squamous mucosa, and being a real benign tumor with very, very high potential for malignization in the urothelia. The unistratified epithelia is generating as a benign tumor an adenoma. And we already saw these adenomas being, like all benign tumors otherwise, well delimited nodular tumors inside the glandular organs, or eventually being as a cystic tumor on the surface of the ovary. And now the idea that when the organ with glands has a lumina, like the digestive tract, and has in fact glandular mucosa, the adenomas developing from this location, from a glandular mucosa, are in fact called polyps. But not all polyps are adenomas. Here it's a very important detail, and we'll enter in much more details in the second semester when we'll discuss about this digestive tract polyps and polyposis. For the moment, the idea that a polyp means a tumor growing on the surface of the mucosa of the digestive tract mostly, but not only, any mucosa with unistratified epithelia can develop such a thing, which are sometimes sessile, meaning with large basis of implantation on the surface, and sometimes are pedicular, meaning with a narrow surface of implantation on the surface of the mucosa. These polyps are, as I said, sometimes adenomas, and they are called in this situation adenomatous polyps or tumoral polyps, and they have a risk for malignization. The non-tumoral polyps are pseudotumors, are in fact some sort of malformations of the mucosa itself or hyperplasias, and they don't have any risk for malignization, but the other ones look in the same way. So idea is that when we have such a polyp, if it's unique, we'll remove it. It's better to be removed, because if it's adenoma, have a risk. If it's not, has not, but why not to remove it? And if they are in large number, and we are calling this situation polyposis, at least one of them should be removed, because it is by principle the idea that if we have a large number, all of them are of the same type. So adenomatous polyps or non-tumoral polyps. And in this way, we know what to do. If they are adenomatous, the risk of malignization being very high, we'll try to remove all of them if it's possible, one by one, if it's not in very large number. Or if it's in very large number, like in thousands or more than thousands in number, then we should remove the entire large bowel, for example, in which these polyps are to prevent the apparition of malignization. This is how they look, the pedunculated ones, so they have a narrow implantation basis on the surface of the mucosa and have a nodular cap, tumoral cap, and the sessile one with a large basis of implantation are, and as we'll see microscopically too, have a villose type aspect, meaning the surface it's mimicking to have villosities and have a large basis of implantation, and this type has a very high risk for malignization. And in fact, some adenocarcinomas, meaning malignant tumor of the gastrointestinal mucosa, can look macroscopically identical. So from this point of view, this type of polyps are the most suspicious one. When they are a large number, like we see here, they are called polyposis. Possible to be some of them adenomas, some of them non-tumoral polyps with no risk. We'll see a lot of such syndromes, generating such type of polyps, but discussing in detail only in second semester. They can evolve, these polyps, sometimes with some minor complication like torsion. It's the case especially for the pedunculated one, which have these large tumoral caps on the edge of the narrow implantation basis, and for this reason they can easily be suffering a torsion, and this way the vessels inside the pedicle of implantation will be occluded, and the tumoral cap will suffer a sort of necrosis, a sort of infarction if you want, but only affecting the cap, and will be detached from the lumina, and in fact they are operating themselves, they are removing themselves without doing anything from outside. Sometimes when they are very big, such polyps can eventually obliterate the lumina, which is quite rare because they don't grow so much usually. They became eventually malignant to grow so much, but as a benign, very rare to be in this situation. And also can suffer on the surface ulceration and hemorrhages. The malignant transformation is possible for both of them, but it's higher the risk for the sessile villose. And here at microscopic level, we can see such a polyp with narrow implantation basis on the surface of the digestive tract, made entirely by glands. This is why it's an adenoma, in fact. It's a proliferation of glands on the surface of the mucosa. This has but low risk for malignancy. And here it's another one, with again a narrow implantation basis, and again with a cap made entirely by glands, proliferation of glands. But here we can see that on the surface of the mucosa we have, with a large basis of implantation, something having villosities. This villose adenoma sessile, being macroscopically, has a very, very high risk for malignization. Now we finished with the benign, epithelial tumors, and we'll start to discuss about malignant ones, all of them being called carcinomas. So all the malignant tumor arising from epithelia. Unistratified, multistratified, all epithelia generate carcinomas as malignant tumors. They are usually appearing in elderlies, but very few of these carcinomas can even appear during childhood period. Is the case for hepatocarcinoma, for example, who has as etiology infection with chronic infection with hepatitis B or C virus. And if this infection is very early during early childhood, meaning in the first year of age, for example, it has enough time for evolving a malignization in the childhood period. So extremely rare, but is possible to have such hepatocarcinoma in children. The rhinopharyngeal carcinoma, also generated by Epstein-Barr virus infection, it's almost entirely, extremely rare, but entirely affecting children, and very rare being seen in adults, and even then in young adults only. Thyroid carcinoma, it's mostly affecting women. As you can see here, women are mostly affected by some tumors, between them thyroid cancers. And it is quite frequent to appear during late childhood period, meaning at the age of 16, 17, 18, something like that. As a constant presence in incidence on the surface of our planet. And this constant presence is put on direct relation with the constant cosmic radiation that we receive. It's very low, this incidence, but is a constant presence. A little bit higher in some industrial areas where local irradiation because of industrial activities is present, so a little bit higher the incidence. But it was for a short period of time, this incidence of thyroid carcinoma growing with 400% after Chernobyl explosion. In Europe, which was in this way contaminated with radioactive iodine. This iodine, liberated in the atmosphere, was entering in the soil, from soil in plants, from plants in our food, and entering in our body. Iodine is selectively deposed in the thyroid gland, where is needed for generating the thyroid hormones. So in this way, the radioactive iodine was selectively accumulated in the thyroid gland, and because of this selective radiation, in the next 2 years after Chernobyl explosion, the incidence of thyroid cancer in children mostly rised a lot. But fortunately, after 2 years, this radioactive iodine disappeared, having a very short life, and now it's regained a normal basic incidence. As we can see, some of these carcinomas have a predilection for a particular gender. A man which is more frequently addicted to smoking is generating or is suffering more frequently by smoking-related cancer, mostly pulmonary cancer, but also laryngeal carcinoma, which is also smoking-related, and even pancreas carcinoma, which is smoking-related, but also related with other chemical substances exposure. Woman has a very, very, very intense predilection for uh, hormonal-related cancer like mammary or breast carcinoma. They are 200 times more frequent in women, this breast carcinoma, than in men. Men also can develop such a thing, but exceptionally rare. And for women, it's one of the most frequent cancers. But for the rest of these carcinomas, the distribution is equal between genders. Otherwise, macroscopically, we already discussed in generalities about tumors. They are, most of them, gray-white in color, having a firm consistency. As an exception from the general rule, hepatocarcinoma, when is well differentiated, and only when is well differentiated, maintaining the capacity of the tumoral cells to produce bile, it's turning the color in green. Renal cell carcinoma, another very particular type of tumor of the kidney, obviously. It's yellow in color because have this property of accumulating in the tumoral cells lipids. The usually firm consistency has also an exception. In the stomach mostly, but possible in other locations like in the breast, including some of this carcinoma, also very well differentiating being, remain with the capacity to produce mucus. And they are called for this reason mucinous carcinomas. And they are producing in the tumor a lot of mucus, and for this reason the consistency, it's more like a gel than firm. It's quite rare to see such a thing, but I had the occasion to see such a case, otherwise dying with it, from appendix in origin mucinous carcinoma in a girl only 15-year-old, just a few weeks ago. She died because of it. Extremely, extremely rare, at least in my experience until now, the first such case in a child, because in adults is more frequent. They are growing on surfaces vegetative, ulcerative, or infiltrative, or a combination of this, or when they are growing in the deep of a compact organ, they are nodular. Otherwise, respecting all the rest of the characters for a malignant tumor, meaning growing rapidly, infiltratively, generating metastasis, and so and so. Usually they are unique, but they are possible to be multiple sometimes. And their dimension, it's varying from a few millimeters to as large as several centimeters or even larger, but never becoming giant as benign adenomas have this possibility. These malignant tumors are never giant in dimension because they kill you before. And this is such a not at all small but quite large pulmonary carcinoma, one of our cases, local cases here from Cluj, seeing that it's nodular in a compact organ being and gray-white firm in consistency. In all malignant tumors, including in carcinomas, because they grow so rapidly, between the vascularization of the tumor and the growth of the tumor appear an imbalance. And this imbalance will generate inside the malignant tumor extremely frequent what we call in one in fact in two words, secondary changes, meaning appearance of necrosis, hemorrhages, and eventually in the necrotic areas we can see a resorption of them, appearing pseudocystic spaces in the malignant tumor, or to appear calcification in the necrotic area. Especially the calcification is extremely helpful for the diagnosis for such a malignant tumor for the breast. When a mammography is done for screening of breast cancer, what they are looking for are these microcalcifications in the breast, which are helping them to put the diagnosis a lot. But they are all of them secondary changes produced because of this growth pattern. At microscopic level, all carcinomas, all of them, have a pattern of structure, meaning the tumoral cells are growing in smaller or larger islands, or sometimes the islands are replaced with trabecular chains. But between these islands, we have otherwise completely benign, normal-looking connective tissue stroma, and inside some vessels, capillary or small arteriolar vessels, which are obviously responsible for the nutrition of the tumor. But the tumoral cells are all together grouped in islands or trabecular cords. These islands, as we'll see, have a different look according with each type of carcinoma, but this general pattern is present in all carcinoma. And we'll start now to see this different type of carcinoma, starting with the basal cell carcinoma, which is somehow it's considered to be a borderline, despite the name of carcinoma. It's a sort of borderline tumor because it's biologically appearing on the surface of the skin only, and it is in fact the most frequent cancer of the skin. But despite the name of carcinoma, it's affecting very aggressively locally the skin, being infiltrative, destructive, but it's extremely rare generating metastasis. It is generating metastasis, but so few cases were described in the world with metastasis from such a basal cell carcinoma that we theoretically and practically consider this possibility as being none. It's mostly appearing on those surfaces of the skin exposed to the sun, being related with UV radiation, and obviously more frequently in those which are exposing them, being workers in outside environment, workers in sunny countries. They are more exposed to appearance, more frequently affected by the appearance of this basal cell carcinoma. So again, it's only for the skin because the origin, in fact, it's in the hair follicle, and only the skin has hair follicle and not the mucosas with squamous epithelia cover. Mostly this basal cell carcinoma macroscopically generate initially or a nodule growing, so it's a vegetant initially tumor, which very soon will generate necrosis inside the nodule, becoming ulcerative. So nodular ulcerative growing pattern is by far the most frequent one, but it's not the only one. And here it's the big problem with the macroscopy of basal cell carcinoma, having other possible macroscopic aspects which can induce, unfortunately, wrong differential diagnosis. When they are not diagnosed early and not removed surgically early, they can grow very, very large, destroying extremely extensively by infiltration a large surface of tissue, and being ulcerative mostly, as I said, this growing pattern, ulcerative growing pattern, is called also ulcus rodens, from Latin. Another, fortunately rare form, macroscopical, is the pigmented basal cell carcinoma, which is brownish in color, being easily macroscopically confused with melanoma. Not microscopically, so from this point of view, a simple biopsy will make easily the differential diagnosis. Again, another form is called the sclerosing basal cell carcinoma, which appear as a scar depressing the surface of the skin, but appearing without reason, meaning without any trauma before, so no reason for a scar to be present there. But it is looking like a scar. Again, if it's not removed early, will grow. The scar has not such behavior, the normal scars, but this form will grow. And obviously, in a certain moment, a biopsy will be necessary to see exactly what's about. And after that, the diagnosis, it's very, very clear, because at microscopic level, we don't really have problems for such diagnosis. And another form, again, confusing, it's the superficial basal cell carcinoma, also called erythematous basal cell carcinoma, because it looks like red with desquamation on the surface, spot on the surface of the skin, being easily confused with an eczema. Eczema being infections, particular types of infections of the skin, are treated with ointments, sometimes with antibiotics, sometimes with antifungical, sometimes with cortisone, and sometimes in a combination of all of this. And if you try as a dermatologist all these treatments for an eczema, and the eczema it's not reacting at all, by contrary, it's growing, then a biopsy should be necessary to see exactly what it is, and then the diagnosis will come. This is the nodular aspect for the growing on the surface of the skin, sometimes ulceronodular, as I said, so in the center of the nodule, a small ulceration starting to appear. And if it's neglected, the ulceration becomes larger and larger and larger, destroying everything beneath, meaning the soft tissue, but also the eye, the skin, the subcutaneous tissue, the muscle, the bone, and invading inside the sinuses and inside the neurocranium including, and when is infiltrating in the neurocranium, despite this otherwise borderline evolution, meaning aggressive locally but no metastasis, such a neglected basal cell carcinoma can kill if it's neglected so long time. Obviously, later diagnosed, the surgeon who need to remove it entirely will have a much harder task. It's not only harder for the surgeon, but also more mutilating for the patient itself. So it's best to be admitted, to come to the doctor when you have such suspicions, to dermatologist or any other doctor, and to see what's about and to have an early diagnosis, because otherwise early diagnosis will be easily removed surgically entirely and with healing end of this treatment. So most of these basal cell carcinoma can be easily healed if they are early diagnosed. Here the pigmented form easily confused with melanoma, macroscopically, clinically. The sclerosant scar-like form here, and the erythematous superficial form confused with an eczema. Microscopically, we have, as I already said, the same structure as all carcinoma, meaning grow in an island of the tumoral cells surrounded by stroma made by normal, otherwise connective tissue and small vessels. What is particular to this basal cell carcinoma is the fact that the proliferation of the tumoral cells in the island is a proliferation with elongated cylindrical cells, which are very similar with the basal cells of the squamous epithelia. And they are growing, these elongated cylindrical cells, with very large basophilic nuclei, with small otherwise quantity of cytoplasma. They are growing at the periphery of the island, being parallel between them and perpendicular to the periphery of the island. And this behavior is called palisadation. Inside, because otherwise the island is full with such cells, but inside the elongated cells are growing in any direction you want. So they are not in a certain order inside. So this is the typical basal cell carcinoma, how microscopically look, and make, for this reason, extremely easy the diagnosis. Here another such an image of islands with palisadation of the periphery. Another one at higher magnification to see even better this phenomenon of palisadation on the border. So the diagnosis at microscopic level is fortunately easy, being extremely difficult to have confusions, but there are. But this is our problem. Unfortunately, some other tumors than basal cell carcinoma, which are called basaloid carcinomas, and they are with origin in something else than squamous epithelia, being our problem for differential diagnosis, and we have our criteria for this differential diagnosis. So in evolution, it is growing by infiltration and destruction of everything if it's not removed. If it's not removed entirely, it's relapsing. So the surgery needs to be extremely precise to have a chance for healing. And they don't generate metastasis. In practice, this means that the surgeon needs to remove entirely the tumor, but it's not needed to remove the local lymph nodes. By the way, when the surgeon is removing, this being the ulceration of or the nodule with basal cell carcinoma, he is removing as much as possible healthy tissue in the surrounding, not only at the periphery, but also in the deep of the nodule. And when we receive such a tissue sample as a biopsy, they usually take only a small slice because from the result of biopsy, they only want to have from us the result that is a basal cell carcinoma. But when is a surgical attempt to remove the tumor, they give us the entire slice of tissue, and we are cutting it in this way. And obviously, in the center, the basal cell carcinoma will be again visible. But what is now the most important information from us for the surgeon, it's and we should do it again and again, it's to have information how the edges of the tissue slice that he gives us, how is at microscopic level, meaning it's positive for the tumor or not. So we are exploring these edges on our microscopic slides each time extensively, because this is the most important for the surgeon and for the patient, obviously. Result from us that the edges are free. If it's not free, even one small such basocellular island, it's somewhere here in the contact with the edge. So if microscopically even one tumoral cell is there, it's obviously another part of the tumor is present remain inside the patient, so it need to be reoperated to remove even this, if it's possible. If it's not possible anymore to reoperate because already was everything possible done to remove the entire tumor, then at least with radiotherapy to insist in that particular area of the remaining tissue to kill the remaining cells. And in this way, it's possible quite frequently in this case to obtain healing. Now we'll see another type of carcinoma, also with origin in squamous stratified epithelia, which is called squamous cell carcinoma. Having the possibility to appear again on the skin, but also on the surface of squamous mucosas. And we have here in red the locations where such squamous mucosas and skin we have, so the entire surface, but also the oral cavity, the pharynx, and the esophageal tract in the entire length. In the respiratory tract, we have also squamous mucosa in the larynx and the first third of the trachea. We also have squamous mucosa covering the vagina and the exocervix of the uterus, only the external part of the uterus. In all these locations, on squamous mucosas, being the squamous cell carcinoma can appear, and when appear on a mucosa, some, not all, are calling it epidermoid carcinoma. So epidermoid carcinoma and squamous cell carcinoma is the same thing, only the location of it is different. What is extremely interesting and important also is the fact that it's possible for this squamous cell carcinoma to appear also from squamous metaplasias. And we discussed that such metaplasia is appearing in smokers in the large bronchial tract of the lung. And for this reason, the most frequent cancer in the world being the cancer of the smoker, the pulmonary cancer of the smoker, is in fact a squamous cell carcinoma, starting from this squamous metaplasia. And it is for this reason extremely aggressive, because in contrary than basal cell carcinoma, which was not able to generate metastasis, this one is. And it is doing it quite easily. An extremely important idea also coming with the squamous cell carcinoma is the fact that before having a squamous carcinoma, we have a pre-neoplastic lesion called dysplasia. Also, it's possible to name it squamous intraepithelial neoplasia or in situ carcinoma. This dysplasia consists in a proliferation of the basal layer of the squamous epithelia, which proliferation can occupy 1/3 from the thickness of the squamous epithelia, and then it's called dysplasia of grade 1. To be even more, 2/3 from the thickness of the squamous epithelia, and then it's called dysplasia of grade 2, or to occupy the entire thickness of the squamous epithelia, this basal layer proliferation, and then it's called dysplasia of grade 3, or absolutely equivalent in situ carcinoma. In situ in carcinoma means also that it's still not yet, it's the cancer is already, but it's still not yet able to penetrate the basal membrane of the squamous epithelia, so it's not invasive, so it's not yet able to generate metastasis. So as long as it is as a dysplasia, even of grade 3, which is already cancer, it's not anymore a pre-malignant lesion, it's already malignant, but not yet able to generate any complication at all. And this process of evolution for dysplasia, it's taking time, around 5 years of evolution from grade 1 to grade 3. And it's even possible for grade 1 and grade 2 to be reverse to the normal. So it's not necessarily always to gain the grade 3 level. But once the grade 3 is there, the reversibility is not anymore possible. So if it's not diagnosed in this late but still early moment, the cancer will start to infiltrate and to generate metastasis. Macroscopically, on the surface of a mucosa, this dysplasia look like a white plaque, meaning leukoplasia. This is why we discuss about it when in metabolic disorders we discuss about keratotic disorders. But on the surface of the skin is not a white plaque, but more like an erythematous plaque. Even for mucosas, it's sometimes erythematous, so not always white. And in this way, it's attracting attention, making possible an early biopsy to have an early diagnosis, and removing only the surface of the skin or of the mucosa will also remove the cancer itself extremely easily with no other complication at all. It is the case, for example, to do such early diagnosis by Papa Nicolau test for the cervical location of this cancer. As I said before, the exocervix of the uterus is covered with the squamous carcinoma, and it is the origin of the extremely frequent in women cervical carcinoma of the uterus, which is a squamous carcinoma. But starting as a dysplasia, it's possible to have an early diagnosis by Papa Nicolau test, which is scratching from the surface some cells, having them on a slide and have a microscopic examination of them. We can see if it's pre-neoplastic lesion there or not. For this particular location, for the cervix, the grade 1 dysplasia is also called CHIN 1, meaning by CHIN cervical intraepithelial neoplasia grade 1. CHIN 2 and CHIN 3. So we have a particular name for the grade 1, grade 2, grade 3, which is otherwise applicable for any other location with squamous epithelia being always preceded in the appearance by such dysplasia. Here it's another extremely easy to be confused problem for you, for students. It's the fact that before developing a squamous cell carcinoma, we have a proliferation of the basal cells. But this proliferation, which is bigger and bigger and bigger, occupying more and more from the thickness of the squamous epithelia, at the end, the result will be an invasive squamous carcinoma and not an invasive basal cell carcinoma. The basal cell carcinoma don't have such a pre-neoplastic lesion being present. So here is a source of confusion. Be aware. Here a very nice otherwise image of these elongated basal cells occupying 2/3, so dysplasia of grade 2 from the squamous epithelium, occupying the entire thickness, very well delimited from the normal otherwise squamous epithelia, and is this image taken from the exocervix of the uterus. When Papa Nicolau test, it's coming with the suspicion that we can have such dysplasia here. It's not for Papa Nicolau to decide if it's or not. It's just the suspicion. This is why it's just a screening and not a diagnostic test. Because with this suspicion in Papa Nicolau test, a biopsy should be taken. First of all, a colposcopic examination, meaning a much closer examination of the surface, looking at it, seeing the leukoplasia being there and taking a biopsy from. And on a biopsy, we'll see such a thing on a pre-invasive carcinoma or in situ carcinoma. When it's becoming invasive, so when it's more advanced, this squamous cell carcinoma is growing as a vegetant, ulcerative, or infiltrative tumor on the surface of skin or mucosas, or nodular when it's growing in the deep of a compact organ, like it's the case for the lungs, for example. Starting from the bronchial tract, it's called bronchopulmonary carcinoma, in fact, but being like a nodule. We saw such an image earlier. Here it's such an mostly vegetant, a little bit ulcerative tumor of the skin, which for this location being on the skin, it's possible to be squamous cell carcinoma, but it's also possible to be basal cell carcinoma because both of them on the skin being located look in the same way. And only the biopsy will be able to make the difference, and is imperative to do it before anything, because otherwise, being in both situations, being a carcinoma, they need to be removed with as much as possible normal tissue. So it's a removal, oncologic type of surgical removal, but also in the squamous cell carcinoma, it's needed in the same operatory time to remove all the local lymph nodes, because this one is generating metastasis, and in basal cell carcinoma, you don't need to do it. So it's a completely different surgical approach according with the result of a previously biopsy taken from here. When is a ulcerative, vegetant, or infiltrative not important, but when it's located on a mucosa, like here on the lateral side of the tongue, one of the most frequent otherwise location for a squamous carcinoma in the oral cavity. So when is here located, it's clear that it's basal cell carcinoma cannot be, because it's mucosa. So only squamous cell carcinoma remain in the diagnosis. Here another such squamous mucosa is the esophagus, who can produce vegetant tumors or ulcerative tumors in any segment of the esophagus. And here, starting from the large bronchial tract, a nodular tumor growing infiltratively in the lung itself or from the lung in the mediastinal space and compressing from outside the trachea, which is here the squamous carcinoma of the bronchopulmonary origin of the smoke. Here a vegetant tumor, here it's an ulcerative but infiltrative tumor of the cervix. So again, squamous carcinomas. They can reach such advanced stages only if the woman affected by particular types of human papilloma virus infection. So not all types, just some of them are able to induce cancer. And women are extremely frequently infected by such strains of human papilloma virus. But as a dysplasic lesion, the lesion is staying there for 5 years. If the woman is doing what is otherwise indicated by medical education, all women should know that at least once at 2 years time distance, if she is performing a Papa Nicolau test, she have in 5-year evolution time at least twice the occasion to have an early diagnosis for such exocervical carcinoma of the uterus, and to remove it easily by a local intervention of the exocervix only, and to remove it entirely and to heal in this way the cancer. If it's not well educated, the woman, and she is not doing the Papa Nicolau test regularly, she risks a lot to develop these more invasive forms, which has otherwise a very high rate of mortality, because they also, being squamous carcinoma, they generate easily metastasis. At microscopic level, we have the same general pattern of islands with stroma surrounding, connective tissue with small vessels in the surrounding. The difference is the fact that these islands are made by atypical, it's true, but large squamous cells, meaning with a high quantity of cytoplasma, larger or smaller nuclei inside, it's true, but with atypia, mitosis, but in some, at least, of these islands, completely otherwise full with these squamous cells, it's even possible to have in the center of the island an accumulation of keratin. When this keratin is accumulated inside, they are called pearls of keratin. And they are extremely, extremely easy to be seen and to make the diagnosis for squamous cell carcinoma. And everything is growing in the deep of the skin, so in the profound. We can see here even at this magnification, in fact, it's not a skin, it's a exocervical slice of tissue to remove, in fact, for a biopsy is not made for a removal of an in situ cancer because it's here already invasive. We can see these islands being invading in the deep. And here is how they look, smaller or larger islands having these pearls of keratin inside. When all of them have these pearls inside, they are called well-differentiated or grade 1 squamous carcinoma. When just some have pearls, some other don't have pearls of keratin inside, they are called medium differentiated or grade 2 squamous cell carcinoma. When the islands are all of them without pearls of keratin inside, like here, they are called grade 3 or low differentiated carcinomas. And here is another such an image to see the islands beneath the surface. So it's an invading tumor, it's not anymore in situ. And having this squamous cell looking with very obvious atypia, so each cell is different from the other one, but still having a lot of cytoplasma, large, and having eventually accumulation of pearls inside. And we already saw this image, and we say that we have, according with these pearls of keratin presence, the gradation system in grade 1, 2, 3, and even in grade 4 when the squamous carcinoma, it's not anymore, even in Iceland, organized, it's not anymore a squamous carcinoma, and it's called now undifferentiated carcinoma. From a macroscopic point of view and clinical also point of view, most of these carcinomas are extremely aggressive and dangerous. Squamous carcinoma, it's an extremely dangerous because it is treatable with surgery, with radiotherapy, but it's also quite early and easily generating metastasis. And for this reason, they are extremely dangerous. But still, we have at least one particular form, which is called verrucous squamous carcinoma, growing on the surface of the skin or mucosa, looking very much alike with a somehow larger, but like a verruca vulgaris. So it's only growing on the surface, and it's not at all growing in the deep by infiltration. This very rare, unfortunately, but form of squamous carcinoma, it's easily to be removed surgically entirely, and is practically not generating metastasis because of this growing pattern only on the surface and not by infiltration. And so for this reason, this particular type form, the verrucous squamous cell carcinoma, it's with a very good prognosis, but the others are not so. And now the adenocarcinoma, which is the malignant tumor rising from unistratified epithelia. And we have such epithelia unistratified on the mucosas, like for example in the entire digestive tract, made here in blue, but also in the gland of the digestive tract, like salivary glands, like the liver, like the pancreas, like the prostatic gland, which is not an annexa of the digestive tract, but it's also a gland. Like other endocrine glands, in fact, all of them can develop adenocarcinomas, including the inside zone of the genital tract, female genital tract, meaning the endocervix, the uterine mucosa, and also the fallopian mucosa can also generate such adenocarcinomas. And again, from unistratified metaplasia, it was the case, and we already discussed about, in the lower third of the esophagus, in the context of long duration acid or biliary reflux in the esophagus, unistratified columnar metaplasia can appear and it's called Barrett esophagus. And from this Barrett esophagus, which is, and we already discussed, considered to be a pre-neoplastic condition, easily and frequently adenocarcinoma will appear. We already discussed this otherwise esophagus non-affected by the Barrett esophagus will generate squamous carcinoma. Previously affected by Barrett esophagus will generate adenocarcinoma, both of them being, in fact, macroscopically vegetant, ulcerative, or infiltrative. So again, when we have such an esophageal carcinoma in the lower part of the esophagus, we will need a biopsy before to have a clue what's there, because both of them look very much alike macroscopically. So they are nodular in the deep, with the only exception, major, being the surface of the ovary, which was able to generate a cystic adenoma. But from this adenoma, by malignization transformation, we can also have a cysticopapillary adenocarcinoma of the ovary. Otherwise, in the deep of the organ, it's nodular, and on the surface, it's vegetant, ulcerative, or infiltrative. And here we can see a vegetant tumor growing on the surface of the large bowel mucosa. Here we have an ulcerative gastric cancer, so it's in the stomach. We have here an ulcerative tumor, but also with infiltration, so it's ulceroinfiltrative adenocarcinoma of the small bowel. And here of the rectum, also ulcerative and infiltrative, with necrosis inside as a secondary transformation, and also with a local lymph node metastasis. At microscopic levels, these adenocarcinoma are like all carcinoma made by islands, separated by connective tissue stroma in which you have some small vessels. The difference with squamous carcinoma and basal cell carcinoma is the fact that these islands have a lumina. And having a lumina, they are looking like glands. Tumoral glands, not normal glands, but looking like glands, and being covered by more than one layer of cells having atypia. And even sometimes with a content, a secretion content in the lumina. For some of these adenocarcinoma, which are well differentiated, I already mentioned the fact that they can still maintain the capacity to produce mucus, so we can still have mucus inside. Mucus which will accumulate in large quantity in these otherwise tumoral glands. Also, it's possible to have versions from this general structure, meaning like it was the case for adenomas too, when they are in the liver, they don't generate lumina, so glands, but they are growing in a trabecular pattern, in cords of tumoral cells, like the normal structure of the liver otherwise. And some much any other patterns of growing, we don't enter in much more detail now. Between them, you can see the mucose or mucigen type of adenocarcinoma. So this is the general pattern of an adenocarcinoma. This one is from the stomach, but it's looking extremely identical if it's from the large bowel or from the small bowel or from many other mucosas, for example, for endometrial mucosa and so. And here, it's a very big problem sometimes. If such a tumor Even in the lungs, we can have adenocarcinomas rising from the normal bronchial glands, not from the metaplasia. So this type of adenocarcinoma of the lung, it's not related with smoking. And it is the second in frequency after the squamous cell carcinoma of the smokers. So it's not rare at all, but it's an adenocarcinoma looking very much alike with this one. And all these adenocarcinomas can generate metastasis at a distance. And sometimes we don't know where is the origin of the adenocarcinoma. We only find the metastasis, taken a biopsy from it, and the result will come that it's a metastasis of an adenocarcinoma in the liver or somewhere else. And the clinician asks, okay, it's adenocarcinoma, but from where it's coming? Here the response is quite difficult, but fortunately we have some possibilities to help the clinician. And this is because all carcinomas, we already discussed about this, are positive for cytokeratins. But we have more detailed immunohistochemical markers for cytokeratin. One of them is the pan-cytokeratin, who is marking all the cytokeratins. But we also have, in reality, 12 different types of cytokeratins. And some of them are characteristic for some organs. So, for example, we have a particular type of cytokeratins positive in the lung, another particular type positive in the liver or in the biliary tract, which have different from the liver itself. Another particular type of cytokeratins are positive in the stomach or in the large bowel, for example. So having a panel of such immunohistochemical cytokeratin markers, we can have at least a clue from where it's coming and to give help to the clinician to find the original tumor in such situation, which is very, very important when the original tumor is so small that it's not visible on ultrasound or other images. Like all malignant tumors, it's generating invasion, local destruction, metastasis, mostly by lymphatics, making again necessarily for a surgeon who is removing such an adenocarcinoma to remove it if it's possible entirely, with as much as possible normal looking tissue in the surrounding, and also by removing the local lymph nodes in the same operatory time. They also can generate hematogenic metastasis, much more rare, but not rare at all after all. All the adenocarcinomas of the digestive tract being possible to generate metastasis in the lymphatics, but also by blood in the liver. And as we saw, Krukenberg tumor are particular type of metastasis for a particular type of infiltrative gastric carcinoma. And it was believed that this Krukenberg tumor appeared by transgenomic metastasis way, but as I already developed the idea, it seems that now that it is a very particular lymphatic way of metastasis for a stomach cancer to generate metastasis on the surface of the ovary and uterus. And now the undifferentiated carcinoma, which is, as the name says, such undifferentiated that the cells are not even anymore organized in islands with connective vascular stroma like all the carcinomas until now. They are only an accumulation of atypical, obviously atypical, so malignant cells, but round or large or ovoid or polymorphous in aspect, but just an accumulation of cells without a stroma. And in such situation, they look exactly with undifferentiated sarcomas, which are also undifferentiated but non-epithelial in origin. But it's still important for such an undifferentiated tumor to say if it's a carcinoma or not, because, and this is possible by doing the pan-cytokeratin reaction, which is positive in all carcinoma, including in the undifferentiated one, or eventually the EMA, meaning epithelial membrane antigen. And it is important to make the difference between undifferentiated carcinoma and undifferentiated sarcoma for the only reason that for carcinomas we have a different treatment. So it is very important because it's really different, the treatment. Sarcomas are not very well reacting to radiotherapy, but carcinoma are extremely well reacting to radiotherapy. So radiotherapy should be put on first place in the treatment. And now we finish with the epithelial tumor. Starting to see the non-epithelial ones, also called mesenchymal tumor, or also called soft tissue tumors. These non-epithelial or soft tissue tumors are having the origin in almost any tissue type other than epithelial, and generating from each of these tissue at least one benign and one malignant tumor. And for this reason, we'll have a lot of entities in this group of soft tissue tumor. But as an entire group, they are not so frequent as the epithelial tumors are. We have a sort of Bible for us, a book so thick called Soft Tissue Tumors. It's obviously what's about inside, and discussing only about these tumors and nothing else, because there are a lot of entities, as I said, much more than you can even imagine. But different tumors coming from fibrous tissue, adipose tissue, muscles of both kind, blood vessel, peripheral nerve, cartilaginous tissue, osseous, each of generating different tumors. When they are benign, the tissue of origin, at the tissue of origin, we add the suffix of oma. And when they are malignant, we add the ending, the suffix of sarcoma. So we have fibroma, fibrosarcoma, lipoma, liposarcoma, leiomyoma, leiomyosarcoma, rhabdomyoma, rhabdomyosarcoma, angioma, angiosarcomas, and so and so. So a lot of entities. As a general future for them, for this group of soft tissue tumors, is the fact that they can appear at any age. So the carcinomas and the epithelial tumors, in fact, were much more specific for elderlies and extremely rare, affecting the children. Here they can be at any age, sometimes being present even from birth as birth signs like hemangiomas. Some others appearing later, but still in the childhood period. As we'll see, in fact, the most frequent sarcoma, the sarcoma as malignant tumors, are very rare, in fact, between malignant tumor, between cancers. But from the group of sarcomas, rhabdomyosarcoma, it's the most frequent presence in children's, and the liposarcoma is the most frequent sarcoma in adults and elderlies. It's so frequent, this rhabdomyosarcoma, for example, in children, that until now in this year, I put this diagnosis in 3 cases in my children's hospital. And I still, until the end of this year, have the possibility to find another one because this is in average the frequency for this diagnosis in our hospital, around 4 cases per year. Very few after all, but still important, and very, very few other types of sarcomas. We have all other types too, in children including, but extremely rare. Otherwise, respecting the general rules. So the benign are growing slow, well delimited, and not generating metastasis. The malignant are growing rapidly, and here are generating bioinfiltration easily. Something quite particular for the group of soft tissue tumor is the fact that the benign one are mostly located, most of them located superficially above the superficial muscular fascia of the body, which is covering our entire body. So they are mostly located in the dermal, subepidermal layer of the body, not in the epidermal because they are not epithelial. And the malignant ones are mostly located deeply beneath the surface of the muscular fascia, superficial muscular fascia. For this reason, the superficial benign ones are much more easily early discovered clinically. And at the moment of discovery, for this reason, they are smaller than 5 centimeters in most of cases. The malignant one being deeper, being possible to be located anywhere in the body, but deeper, they are discovered later, and for this reason they are more than 5 centimeters in diameter in most of the situation at the moment of diagnosis. Otherwise, well delimited when they are benign, infiltrative when they are malignant, again respecting the general rules, are nodular in both situation, benign and malignant, because they are growing in the deep, so not on the surfaces. The color being the same with the tissue of origin and the consistency, in fact, for the benign tumor, but for the malignant one, for the sarcomas, they are all of them pinkish in color, looking very much alike with fresh fish meat. Secondary modification like necrosis, hemorrhages, cystic degeneration, calcifications are also present here, even more frequently than in carcinomas. We describe them there, but not present in the benign tumors. So only the sarcomas are doing it extremely frequently, such secondary modification. And at microscopic level, the benign tumors are all of them looking identical with the tissue of origin without atypia. But the sarcomas have a common growth pattern again, meaning this time they are not growing in islands. They are not even having a stroma. They are growing like compact growth of tumoral cells. They are just growing like elongated, round cells sometimes, ovoid, pleomorphic shape, but they are a compact growth, don't having a stroma beneath them. Only a very thin, very fine reticulin stroma, which this means a collagen type 4, which is a very lax web-like collagen fiber type, not the collagen 1, 2, which is generating the connective, normal connective tissue. And the nourishment is made not by vessels, but it's made by circulating of the blood beneath these tumoral cells, like in a sponge. So we have spaces, very small ones here, and the edges of these spaces are made directly by the tumoral cells and not, in most situations, not by endothelia. And the blood is circulating in this way in the tumor, like in a sponge. And this is why extremely easily such tumoral cells can be detached, entering in the blood, and in this way generating hematogenous metastasis mostly and least frequently in the lymph nodes. About sarcomas, now a few general considerations. They are the malignant tumors of the soft tissue. They are, as a group, very rare, fortunately, because otherwise they are extremely malignant ones. Pinkish in color with secondary modifications like hemorrhages, necrosis, and pseudocystic degeneration in most situations. Here, for example, we have two images of liposarcomas. They are here in a muscle, so they are deeper than the superficial fascia, and here also in a muscle, deeper than the superficial fascia. But both of them don't look at all like the adipose tissue, in fact, despite the fact that they are liposarcomas. They look very much alike with tuna fish meat or fish meat of any kind, with necrosis, hemorrhages, and cystic degeneration. The cells of the sarcomas can, in some situations, be differentiated enough to be able to put a diagnosis of liposarcoma, fibrosarcoma, and so, osteosarcoma, chondrosarcoma, and so. But also, unfortunately, much more frequent than in the case of carcinoma, we can have undifferentiated sarcomas, which are, by the way, negative for cytokeratin. This is how we put this diagnosis, and positive for another marker, which is positive in all soft tissue tumor, differentiated or not differentiated, which is called the vimentin. Thus, these undifferentiated ones can be with round cell, fusiform cells, polymorphic cells, undifferentiated sarcomas. And they are a very, very big problem for differential diagnosis. Because, for example, we have such a group, quite a large one, called small round blue cells tumors of childhood. Some of them are carcinomas, some of them are sarcomas, but all of them have round blue small cells in their composition growing as a mass. So they are a problem, a big problem for differential diagnosis. And for this reason, in fact, it's indicated, and in Western countries, it's in current practice, for the final diagnosis, anatomopathological diagnosis of a sarcoma, to have always the diagnosis coming from an over-specialized pathologist who is doing nothing else, just this thing, diagnosing sarcomas. They are rare tumors, so they don't have a lot to work. So for this reason, they are not needed to be a lot of them. In a country like Germany, for example, it's enough 3 of them for the entire Germany. For Romania, it's enough 2. But in Romania, we don't have such a thing. In our country, those who are the most well qualified for giving such diagnosis are our colleagues working in oncologic institutes. Because here, obviously, by the nature of the institute itself, they are working mostly with tumors than other hospitals. So it is sometimes a very difficult differential diagnosis, and this is why that particular books of soft tissue tumor was so big and so important for us, because each time when we have such a sarcoma, we need to open it to be very attentive to the differential diagnosis problems coming with it. And at the end, we still refer our case with our slides to the more specialized pathologist who is invited in this way to have a second opinion, absolutely necessary for a correct diagnosis and treatment. So, as we already discussed, the general composition without stroma, with small vascular spaces, in fact, for circulation of tumor between the tumoral cells, and having this secondary modification discussed. Here it's such a metastasis of, it's written here, liposarcoma. As you can see, in fact, it's just an accumulation of cells, most of them round, and by nothing you cannot say that it's a lipo here. It's very difficult. It's true that in some, very few of these cells, in a special stain for lipids, we can have lipids accumulation, and this is the only detail who is making the differential diagnosis here. Otherwise, being very much alike with an undifferentiated sarcoma, but having just a few cells with lipids inside, it's enough to put it in the group of liposarcomas. Here another such an image with some ovoid, some round cells, some large, some very small cells, just an accumulation of such cells with small spaces between the cells in which the blood is circulating, but also having just a few vacuolar spaces in some of the tumoral cells, positive for lipids in spatial stain, which will make the diagnosis. It's extremely difficult. Again, it was a liposarcoma there. So at light microscopy, it's very, very difficult without spatial stains, and particularly important the immunohistochemistry markers that we have at our disposal. The vimentin is not very useful. It's used, but it's not very useful because it's positive in all sarcomas, not with any difference, but is important for making the difference with an undifferentiated other tumor than sarcoma. Otherwise, we have some markers, for example, CD31 for endothelial cell, desmin for and actin for muscular cells, and so. Metastases are more common by blood than by lymphatics, possible in both ways, but blood is by far the most frequent way for metastasis. And evolve like any other malignant tumor, so it's relapsing easily locally if it's not entirely removed, and is generating metastasis at distance by blood, mostly in the lung, liver, and bone. And now we are starting with the group of tumors originating in the fibrous connective tissue. And it's, as you will see, it's a quite large group, because we have from the fibrous tissue many different tumors. and we will only discuss about a few of them, in fact. One such entity, which is a pseudotumor, so it's not even benign, is called nodular fasciitis. As the name is saying, it's affecting the superficial fascia. So it's not a tumor which is beneath the fascia, it's not above the fascia, it's off the fascia, looking like a nodule and growing extremely rapidly initially, like a malignant tumor. But it's very important, but it's with pain. Usually malignant tumors are painless. This one is growing rapidly with pain in this particular superficial location of the fascia, mostly at the level of the forearm, but possible anywhere on the surface of our fascia. Being the result of a trauma, in fact, of this fascia, and being in reality an inflammation, a proliferative inflammation of it, and not a real tumor. But clinically looks very much like a tumor because it is growing rapidly. And being an inflammation, it's even possible to generate local lymphadenitis, meaning enlargement of the local lymph nodes. And even at microscopic level, in this initial rapid growing phase, the proliferating fibroblastic cells, which are young, are with atypia. And for this reason, it's easily to be mistaken with a malignant fibrosarcoma. Fortunately for the experienced pathologist, it's not a problem because this tumor, it's in fact pseudotumor, as I said, being an inflammation, have inside the tumor the presence of a lot of inflammatory cells like lymphocytes and even some polymorphonuclear cells. And this presence of inflammation inside, it's making the difference. Not for anybody. It's just for the experienced pathologist, as I said. This is why it's so necessary to have a second opinion from a specialized or experienced pathology in this type of pathology of soft tissue. After having this initial phase of rapid growing, the growth is stopping, and in fact it's even involved in a sort of involution after that, because in fact the inflammation is auto-healing without doing anything, remaining from the entire process only a small fibrous nodule, in fact a scar remaining after the healing. But as I said, sometimes the clinician is so intensely convinced that it's a malignant tumor there that it's removing surgically the nodule, otherwise not necessarily to do it at all, because it's just an inflammation with its auto-healing in time. Another pseudotumoral again condition, and is pseudotumoral because this fibromatosis is a group, because it's an entire group of diseases, don't have local genetic mutation presence inside. So they are a pseudotumor, but otherwise biologically being locally extremely aggressive, infiltrative, and relapsing extremely frequently after a try to their removal. But they never generate metastasis because they are not even benign tumors, as I said. But very aggressive locally otherwise. They are infiltrating the tissue of origin, and are microscopically made by otherwise very well differentiated myofibroblastic cells without any atypia or mitosis. So no suspicion of malignancy at all from microscopic point of view, but clinically very high suspicion of malignancy because of this aggressive local infiltrative growth. As I said, we have more than one version, type of fibromatosis, and one group is the superficial ones. The superficial fibromatosis, one member of the group is the palmar fibromatosis or Dupuytren fibromatosis, appearing as a nodule, initially well delimited but very rapidly growing by infiltration in the palm region of the hand. This nodule with infiltration is affecting the tendinous part of the hand, and by this it's generating retractions of the fingers which are handicapping the person and are definitive. Obviously, it's not a very nice thing to have such a deformation of your hand, definitive deformation of your hand, and affecting mostly the men of Nordic ancestry, so Scandinavians, but possible in anybody, but least frequently. So having such a thing, you want to operate and to remove the problem. In fact, by this try, the result will be even worse, because to the otherwise relapsing of the infiltrative fibromatosis, a scar is added. So it's even more the retraction of the finger more than what it was before. So for this reason, the only treatment is by physiotherapeutic approach. Another type of superficial fibromatosis is the plantar one, this time affecting children's and least adults, being located at the level of the sole of the foot as a nodule again, growing with infiltration also, but fortunately without appearing retractions of the fingers, so no deformation of the foot itself. So for this reason, otherwise not painful, not symptomatic at all, it should be let to be and stay and not try to remove, because if you remove, it will be worse, even with retractions of the fingers. Another particular location is the disease called La Peyronie, affecting the fascia of back of the penis and generating very unpleasant and, as I heard, painful deformation of the penis, which is also a permanent one. The image is from a local case. The superficial fibromatosis, it's one group. The profound or deep fibromatosis, also called desmoid tumors, are another group, appearing deeper than the superficial fascia, also by infiltrating the nearby tissue. One possible location is the abdominal wall, most exactly the muscle of the abdominal wall, called abdominal fibromatosis. And another location is the intra-abdominal fibromatosis, when we have the presence of this fibromatosis in the roots of the mesentery. And another group is the extra-abdominal fibromatosis, when it's appearing anywhere, mostly on the surface of the thoracic wall, but possible in any other location. The mesenteric location for fibromatosis is extremely dangerous. I had such a case diagnosed 1 year ago, and because of this infiltrative growth in the roots of the mesentery by vascular compression, this 17-year-old girl last year developed intestinal infarction, which was obviously an emergency, surgical emergency to be removed. And in the removal of the infarction, also they try to remove the fibromatosis. But relapsing again and again, meaning another two other intestinal infarctions developed in the same year. And after that, she entered in the age group of over 18, so she is not anymore a child, becoming an adult, so she is now in the care of an adult hospital, but where she has other relapses, each time being necessary to extract another segment of the intestinal tract. So at the end, despite the fact that it's a pseudo tumor, not even benign tumor, this girl will die because she will remain without intestinal tract at all in this sort of evolution. So for such particular location, they are extremely dangerous, this fibromatosis. Here is such a nodule with infiltration in the muscles of the thorax between the ribs. Here it's in the mesentery. It's not from my case, but it was an identical situation here in this image. And at microscopic level, it's made by otherwise normal looking connective tissue, which is growing with infiltration of any surrounding type of tissue, muscular, adipose, nervous, any kind. It's just infiltrating and relapsing. As a real tumor this time, benign, fibroma has a genetic mutation inside, but fortunately it's a stable one, so it's not evolving, transforming in a malignancy. It's otherwise a small, superficial nodule made by otherwise normal-looking connective tissue and nothing else. Quite rare, in fact. The malignant counterpart, the fibrosarcoma, is fortunately also rare. Only 5% of sarcomas, which as a group was a very rare group of tumors. So they are, these fibrosarcomas, quite rare. Otherwise appearing in deep, in muscles, usually in muscular masses, mostly in locations which were in the past previously affected by radiotherapy for other reasons. Coming like nodules larger than 10 centimeters with necrosis and hemorrhages inside, and having at microscopic level a proliferation of fibroblastic immature cells, meaning with atypia, organize this proliferation in fascicles, interlacing in a herringbone-like pattern. This is the characteristic for the sarcoma. Otherwise, macroscopically non-characteristic at all, any sarcoma can be in such deep location and looking in this way. Only microscopy is able to put looking in this way, so a proliferation of fascicles arranged in a herringbone-like pattern. The atypia is extremely obvious between the otherwise fibroblastic elongated cells. Fibrous tissue the connective tissue, the normal one, also have in his normal structure macrophages. They are called histiocytes, and they have obviously the role of local cleaning of the tissue, being macrophages. But they also can be involved in a tumoral proliferation, generating a separate group of fibrous tumors called fibrous histiocytomas. And because it's a group again, one of the group member is the benign fibrous histiocytoma, obviously having a malignant fibrous histiocytoma too. The benign one, it's respecting the benign characteristics, growing superficially as a firm, well-delimited nodule formed at microscopic level by fibroblastic cells like a fibroma, but also having mixed inside a lot of histiocytes, most of them being giant multinucleated cells called toutons, but also possible some other types of macrophages like xanthomatose cells or siderophagic cells. And also in a certain amount some inflammatory cells too possible to be mixed here. We'll see an image of it in the next slide. Another member, this time being categorized as a borderline, is the dermatofibrosarcoma protuberans. This particular tumor is superficial. Despite the name of sarcoma being so superficial, meaning beneath the surface of the skin in the dermis, it's dermato. It's rapidly, easily seen as a nodule, removed entirely with the healthy tissue in the surrounding. And in this way, it's the metastasis, which is extremely difficult to be produced by this low malignant tumor, will never appear. So the healing, it's the rule here, in fact. Otherwise, looking very much alike with a fibrosarcoma, like we saw it before, but in this very superficial location in the dermis. This is the benign fibrous histiocytoma, in which we have this large number of multinucleated giant cells called toutons, which are characteristic for the histiocytoma benign histiocytoma. And this is the proliferation, again, looking very much with a herringbone pattern of atypical fibroblastic cells in a nodule which is ill delimited. This is why it's needed to be removed with healthy tissue in the surrounding. By the way, from this image, the most important detail for the surgeon who removed this nodule is to say if the edges of excision are free or not. Or here you can see that the edge is extremely close to the excision, the deep excision part of the tissue. And it's indicated in such situation to do it again, the surgery, and to even do it more profoundly to be sure that you remove entirely. And in this way, you will obtain a healing without even being necessarily chemotherapeutic treatment for this superficial dermatomas. The malignant fibrous histiocytoma, as I said, it's a very aggressive tumor, being in fact tumor of all kind of cells mixed here, but also having between them giant multinucleated cells like the two-tone ones, but mixed in this with otherwise polymorphic myxoid or even inflammatory cells. So it's a otherwise very difficult diagnosis of exclusion of other malignant tumors. It's extremely aggressive malignant tumor, appearing mostly deeper than the superficial fascia, having more than 5 centimeters in diameter, having hemorrhages, necrosis, and cystic degeneration inside, and being possible to be as deep as in the retroperitoneal area frequently. Here, macroscopically, nothing to say about the nature of this tumor inside the muscle here, but it's not a muscular. And having inside this very, very atypical cells of any shape, of any type, in any fascicular, non-fascicular arrangement, but mixed with giant multinucleated two-tone cell again. And now we are ending here this lecture, starting next time, which is probably the last lecture to be, with the adipose tissue tumors. Thank you for your attention.